Let me briefly present Marcus Wolf, and I'm very pleased to wrap up this webinar series with him with a presentation titled Digital Mental Health, Hype, Hope, and the Real World, a very provocative title. And I have had the privilege of sharing 2 webinar series in the last 2 years, and I'm very pleased with the quality of the webinars we now have on our website. And I'm pretty sure that we'll have another excellent presentation today. Marcus Wolf is a senior researcher at the Department of Clinical Psychology and Psychotherapy Research at the Psychological Institute at the University of Zurich, Switzerland. His work focuses on health, communication, and mental health service research. And in his research, he develops, evaluates, and implements digital and low-threshold interventions aimed at supporting psychotherapy processes and improving access to mental health care. Some of his research interests are digital mental health, as you can imagine from this title, the title of the presentation today, health service research, prevention, adaptive and stepped care intervention, among many others. So I would like to welcome Marcus. Thank you very much for being here today and to close this webinar series. The floor is yours, Marcus.
Thank you, Miguel, for this really warm introduction. And also thank you for inviting me to this exciting webinar series. Before I start, I'm going to share my slides for you, and I hope you can see them now. As Miguel said, my name is Marcus. I'm a senior researcher at the Department of Psychology at the Chair of Clinical Psychology and Psychotherapy Research, which is headed by Birgit Watzke since a couple of years. So it's a kind of a new chair at the University of Zurich. And before I start, I'll give you a brief outline, and I will then again give you some information about our department. So as Miguel already mentioned, the title is quite provocative, and I really have to apologize for this, for 2 things at least, because digital mental health is such a rich and broad field. Of course, I won't cover everything in this field. So it's such an exciting and fastly developing field. And you can imagine that it's really hard. So I will focus on a very specific aspect, and that's internet-based interventions, as you can see here. And it's also something that I think the handbook chapter is focusing on in the very latest edition of the handbook. So this is a very specific, very fruitful and exciting area of digital mental health, like internet interventions. And I call it a success story. And that's what I labeled kind of hype. But again, this is very provocative. And I think this is a good hype because it was really stimulating a lot of research. And this is probably one of the fields that have produced more research than other fields over decades. And it's a young field as well. So I'll give you some background information about common terms that are used in this field. So there's not really a very consistent use of terminology, but it's good to have them all on mind. And then I'm going to show you why this is a success story. And those of you who have read the handbook chapter or have even heard Gerhard Andersson's excellent talk in the handbook webinar series that also is provided. It was a couple of weeks ago, I think, when Gerhard Andersson spoke about the handbook chapter. Then you already know something about internet interventions, but I'd like to take a different perspective than he did. So we will take a more kind of a bird's eye perspective view on the research that has been done on internet-based interventions, because this is very exciting to learn, also what do we know in this field, and probably what are the blank spots that we already have or still have. And so I labeled this the real world, but it's really like the real research world, something like that. And it's a like more kind of a humorous meaning. It's not really an objective view on the real world in this type of research. So we will have a close look at control groups, a type of control groups in these kind of trials, and we look at sample characteristics in RCTs for depression psychotherapy, And also we have a closer look at the role of human contact in internet-based interventions, because we do know that this is one of the most crucial aspects when delivering these interventions in terms of effectiveness. And then there will be some take-home messages. Yeah, Miguel, you already introduced our chair and my work. And actually, we do have a broad focus. We do some psychotherapy process and outcome research, but we have also a broader focus. So we really also do mental health care research. We focus on how do people access psychotherapy in a specific country, and what are the barriers to access, and what are crucial transitions between different sectors of care. And also, what are the overall long-term pathways of care that the people go through when they seek psychotherapy or help for a mental disorder? And what fits quite well to this perspective that we are interested in very low threshold and also adaptive and step care interventions, like interventions that fit into the healthcare system, that can be adjusted and like fit into the gaps that we really spot in the system. And one specific aspect we are interested in is stepping down interventions for depression. Like relapse prevention interventions or aftercare, like after intense treatment, what do people do when they go back home and there's a high risk for relapse? So we try to develop some interesting interventions, also using digital technology, but also simple as it is, the cell phone or the landline telephone, for the patients to stay in contact with their therapists after treatment. So, and one specific aspect, like clinical wise, is that we are also working on body dysmorphic disorders. There's a group in our department that is specialized on this one. This is a very rare instance that this very important disorder is really addressed. And also we do meta research. That means like we take this kind of bird's eye perspective in the mental health system on questions that we are really into. Yeah, so this is a little bit of background of our work. And before I start now, I'll give you some really basic terminology in the field. Most of you might really know these words, but they have a different meaning. And like the various cell phones that I put on the slide, the definitions and the meanings of the terminology changes over time. And I started with a very important definition, computer-mediated communication, which is really the backbone of all these interventions. And this term dates back to the 60s and 70s, when people started to think about how do people communicate with computers or over computers, speaking of the internet. So CMC is really kind of an important aspect that didn't come from psychotherapy research, of course. It's from social psychology, it's from communication sciences, and also from computer sciences. But that's an important thing to keep in mind, that all these dynamics of computer-mediated communication really apply to internet interventions as well, or smartphone communication. And then we do have the really broad umbrella terms of e-health and e-mental health, like the subdomain that's focusing on electronic applications in mental health. So it's a very broad term. I mean, it's around for 30 years, I think. A little bit more specific is telemedicine or telepsychiatry. And this term really focuses on that we are communicating via distance technology, like video consultations, also to telephone, and like stuff that we are doing here, talking over Zoom. That's really the specific focus of telepsychiatry, providing psychiatric treatment or psychotherapeutic treatment over a communication medium that allows you to talk and to see each other. Then it gets a little bit more specific, like online therapy or internet therapy, or sometimes back in the days also labeled cybertherapy, is a very specific form of using distance communication for delivering psychotherapeutic treatments. And I'm going to show you, it's a kind of a hybrid between telepsychotherapy and internet-based interventions, because it's a little bit richer than pure self-help interventions. That brings me to the next important topic. That's the internet-based interventions, or internet interventions, or mobile-based interventions, like, as we call it, like a couple of years ago, when the smartphones really had the breakthroughs. In other words, what you often read is CCBT or ICBT for internet-based or computerized cognitive behavioral therapy. So these were really the first programs that got developed, and they are still around, and there's a lot of research on these programs, and that's what we actually gonna talk today. about. It's these types of interventions, because the largest share of research is really on these types of interventions. But then there's also another evolution of terminology, like with the upcoming of mobile devices, and everybody has a smartphone. Also the field of M-health and M-mental health were becoming more and more important. And then also a broader topic of digital health or digital mental health came up, which is a little bit more broader than internet interventions, because it really addresses the use of big data and machine learning to process information that is used in internet interventions. I've seen a question in the chat, and I was wondering, Miguel, if I should address them now, or should we collect them? Oh no, it's just a comment. I'm sorry. Okay, so these are some basic information about like the full field of interventions and developments out there, but we will really focus on the field of internet interventions. And I like really this categorization that was brought up first from two colleagues from University of Bern that you all might know if you are around in this field, Thomas Berger and Tobias Krieger, who suggested we could categorize internet interventions along these two dimensions, or any intervention could be categorized along these two dimensions. First dimension would be how much therapist contact is there in this intervention? Do we have full therapist contact, or do we have no contact with a therapist or clinician at all? And then the second dimension is the therapy delivered fully face-to-face, as we know in traditional psychotherapy, the encounter one-to-one setting where the patient comes to the office and will have psychotherapy, or is the intervention delivered fully digital? And if you look at this two dimensions, of course, the conventional psychotherapy will be located at the upper right side. That's quite trivial. And then what I was talking about, like telepsychotherapy, telepsychiatry, and online therapy, who have a lot of amount of direct communication via video or chat, that would be located in the upper left side of this dimensional space. But now it's getting interesting, because now we're approaching the areas that have actually most research around. And these are the so-called guided or self-guided internet interventions, or self-help interventions, or, as I said before, CCBT or ICBT. So they fall all under this umbrella. And as you can see, we have a guided version where a therapist is involved and delivers some therapeutic contact via direct interaction, usually via email, but sometimes also with video consultations. But then there's also the minimal contact self-help, and also the purely self-guided and self-help internet-based interventions. And these three interventions have really produced hundreds of randomized control trials during the last 10 to 15 years. And I will talk about this literature today. And then there's also something which came up quite before COVID-19 started, and that's called blended therapy. That's a mix and a blend of real therapy, real-life therapy with digital therapy or internet intervention. So like you do have a service provider which you have a individual psychotherapy, but in between the session, for instance, you use a internet program to train or use or exercise or work on certain aspects. So this is really something that's coming up more and more, and it's kind of it seems to be kind of the gold standard. But interestingly, we have not much research around in blended therapy. So this will be very important to see, okay, how to blend, when to blend, and how this can all be delivered and coordinated. So again, as I said before, this is the field where we have most of the research at the current time. And just to give you an example of what I'm talking about, I just brought two programs today, because there's many programs out there that have been developed at universities, at research groups that were very productive. But I just brought two examples because these were the two of the oldest programs that at least I am aware of. And I hope most would agree, but of course, there's other groups that are very productive and have developed stuff. So the first example is the InTherapy protocol. that has been developed by Alfred Lange and his group in I think at University of Amsterdam. It dates back to 2000 and I think 1998. He published one of the first papers on InTherapy, so you can see it's quite around quite a while already. And it gives you kind of the typical protocol. This is a specific protocol for post-traumatic disorder, but the protocol is quite similar for many, many CCBT programs. Although the InTherapy approach has a little bit more therapist contact than the guided self-help approach. We will talk about this later probably. So you do have a screening in the very beginning, then you have kind of exercises, and you have some cognitive aspects in the training. And then there's sometimes there's a ritual phase, a goodbye phase where you end the internet treatment, and then there's sometimes an evaluation and post-test and everything. So this is a typical protocol. And then there's another example that I brought, that's MoodGym. Some of you might have heard it. It's also around for, I think, almost 30 years now. It has been developed in Australia by the group of, I don't think that you can see the paper correctly, but Helen Christensen and Kathleen Griffith, together with Anthony Jorm, have developed it and first published a very influential paper in BMJ back then. I think it's 2000 something, 2004. And MoodGym is still around, so it has been a little bit enhanced. It had the design changed a little bit, but basically the protocol of MoodGym is still there. It covers also psychoeducational aspects, cognitive, affective, and the typical ingredients of cognitive behavioral therapy within 10 to 15 sessions that can be worked through by clients alone on their own or with guidance together with a clinician. So these are really two very typical examples, but there are many more. And I think also in the handbook chapter, there's another example from Gerd Andersson and Thomas Berger's groups that you could look at. So yeah, there are many, many around. Yeah, so let's jump into the topic. First up, I mean, there's many, many hopes and also chance and opportunities that are connected with internet interventions or digital interventions. And they have been discussed for 10 to 20 years, I think. And I think we're quite good in getting there. But still, there are some challenges open, which we will discuss today. So we'll start with three important aspects that were really mentioned and are always mentioned really at the beginning when you talk about digital interventions. We have really the opportunity to reach many, many more clients or patients by using distance technology, of course. I mean, that's trivial, but it's so important because we know that access to treatment in many countries, even in the highly developed countries, such in terms of healthcare systems like Switzerland or Germany, many patients wait for treatment very long, and they do not get adequate treatment. Kind of in between different types of treatment that are available, but usually that's not really the one that they should get. So access can be improved, and the reach of specialized services could be extended over countries also, so people can access specialized treatment on a certain topic over the internet easily. And then something also that's often promised is it's highly scalable. Specifically, the fully self-guided interventions, I mean, they're totally scalable. So everybody could access them. You have to translate them to a certain language, and then everyone could, in principle, use them. So it's highly scalable. It's a little bit different for blended interventions, of course, but we will talk about the unguided self-help today also. And then there's some really some benefits for patients. Using these programs can be very flexible. So they are around 24/7, and I can access them and start them and work through the program whenever I have time, and also like a quiet space to work. I don't have travel time. I can just sit in my office and use the hour to work through the program. And also, which is very important for some client groups, it allows some anonymity. So staying behind the screen and doing the work in a program for some clients is really attractive because they fear stigma. And so there is a subgroup of clients that can clearly benefit of using programs without being stigmatized. And also, what happens is that there's some empowerment involved and some democratization process because the client and the patient are on the same level. if they do therapy over the screen or if the patient works on his or her own. So self-management skills are trained, and the patients are really much more in charge for progress. And this is kind of really an important aspect. It can also be considered a unspecific factor in these programs. And finally, we do have some really, really important benefits for the healthcare systems, because using distance communication tools and digital devices can really help us doing things like integrated care becoming real. We know that it's really hard to set up a stepped care system or provide seamless care, and digital tools can really help to model the transitions between these integrated care sectors, and via monitoring or also consultations that can be done over the internet and so forth. And then something that's also possible is, because everything is data-driven, we can highly personalize interventions based on things that we assess during treatment. Routine outcome monitoring is a classical example that's around for, I think, a couple of decades already. But you can also do this in interventions where you really tailor the intervention to the needs of the patient based on the data that he or she provides. And also we can tailor the intervention on temporal and dynamic aspects, like in just-in-time adaptive interventions or ecological momentary interventions, EMIs, where we use the data to adjust the treatment while it's ongoing. So not only at the beginning where we take into account patient factors, but also during treatment, the treatment could generally be adjusted. To be honest, I'm not aware of many programs that are doing this already, but this, I mean, that's a clearly benefit, and that will be something that will happen in the future. And there's also a promise in kind of more societal benefits that probably health disparities could be removed by providing access to underserved groups of patients, or those who are stigmatized or who are not living in an area with a good treatment availability. So there's some promise around there. I'm not sure if we have kept them or all these promises. I think this is still on a very important aspect that we should be better in providing access to underrepresented patient groups and those underprivileged population groups that haven't been accessing psychotherapy so far. And in the end, of course, there's always some cost effectiveness in the room. I mean, if you are able to provide scalable interventions to patients who are completely fine with it, for instance, people with moderate or mild symptoms, you could save resources for other clients who need more. So this really resource allocation could be a very attractive aspect in terms of health services systems and cost effectiveness. So you can see there's many hopes that are connected with internet-based interventions, and I think they have really triggered a lot of research that was going on during the last, I think it's 40 years is covered by this nice slide. I took that slide from a publication by Sale et al. From journal Internet Interventions, and this just gives you the development of publications on the topic psychotherapy and technology. So it's a very broad search criterion. Okay, it's not only internet interventions; it's much broader. So that's the reason why we have so many publications here. But you can see, like in the early 2000s, it really caught up speed. So we have really a proliferation of randomized control trials on internet interventions, and that's really well represented or well reflected by this nice slide. And it started quite, I think we started, when I started in working in this field, that was back then in Heidelberg, at the University of Heidelberg, at the group of Hans Kordi and Steffi Bauer. And I'm not sure if I can see someone around from the group, but probably there's one in the room today. And I started there, that was kind of 15 years ago, and around early 20s, 2010 something. And we were around there and probably contributed to one of these 50 to 60, 80 studies there. That would be interesting to see, actually. Okay, so you can see there's really an explosion of publications and of research by many groups, but there were also some very productive groups, like in Scandinavia, in Australia, we do know groups, and also in Switzerland, Thomas Group And then also in Heidelberg, the group was very active in this field. So at the moment, and actually this is not at the moment anymore, because I cited the handbook chapter here, which has been published in 2021. So it's already outdated, but Gerhard and Thomas wrote in the chapter that at least 300 RCTs for a range of client conditions and disorders are around at the time the chapter has been written. So I would assume it's at least a third more today. So we have 400, 450 something. I mean, that's really, so many trials have been and are still publishing on many, many different conditions. On depression, I think I'm aware of at least 70 RCTs that are really focusing on internet intervention, on symptoms of depression or the depressive disorders. I mean, there are many more around on depression and technology and digital health, but like internet interventions on depression, I think there are probably 70 trials. And it's interesting that to see that we have more than 40 meta-analyses summarizing these trials. Of course, the meta-analysis, they change the focus, so we have different foci that they're looking at, but we have many, I mean, meta-analysis is really a field that is also exploding. We have so many meta-analysis and yeah, sometimes they are a little bit contradictory, but sometimes they are confirming stuff and then they're updating and they're switching the focus a little bit. So it's really hard to keep up with meta-analysis actually. And one of the most recent and very large meta-analysis that has been conducted by Moshe et al. From Harald Baumeister's group in Germany, I think it's been published in Psychological Bulletin, has an average total effect size of 0.52. So this is really lumping all the internet-based intervention studies together. And it's very important to disentangle this evidence. And that's what we are going to do in the next few minutes. So, but that's the average total effect size. And most of you know that this total effect size is sometimes not really very informative. So, but you can see this is a highly productive field and highly productive groups working in this field. And so if you look at the handbook, this is the 6th edition, you couldn't find much about internet interventions in the handbook. It was really hidden in certain chapters. For instance, we have the chapter on behavior therapy with adults here. And there's a small paragraph on internet-based interventions there. So you had to really look for it. And I think it was also a chapter, a small paragraph on internet relapse prevention that was based on stuff that the Heidelberg group did. But it was really not much. And that has totally changed with the latest edition of the handbook, where we have a full chapter only devoted to internet interventions. And I think this is a very dense, a very full chapter written by Gerhard and Thomas, showing you really as I would label it, the success story. So really the proliferation of findings, results from all various aspects that trials have been addressing so far. And I think this is really a kind of a success story. And here are some quotes that kind of mirror this. The first is taken from the chapter. It's at the very end, I think, where the two authors say, it could be described as a revolution in treatment research. It may be well that we face a situation in which there's more empirical support for internet intervention than for regular face-to-face psychotherapy for some disorders and conditions. And that's really hard to read. I mean, doing psychotherapy research for decades, and then there's a field that is starting 20 years ago, producing more randomized controlled trials than other fields. That reads really, that's hard to really believe and also to digest. And then there's another conclusion that's coming from a meta-analysis that has been recently published. Also, I think it's the group of Gerhard Andersson on the comparison of face-to-face versus internet-based psychotherapy. So the direct comparison of face-to-face versus internet therapies. And they conclude that overall, clinician-supported ICBT yields similar effects compared to face-to-face CBT. Although more studies are needed to reduce the uncertainty of effect estimates for individual clinical conditions, we regard it as unlikely that the addition of new randomized trials will change our confidence in the overall conclusion that internet-based interventions can be as good as face-to-face psychotherapy. So this is another conclusion that's been drawn from this really evolving field in the past. And that's very important because it does have impact on health services in different countries. And I cannot focus on everything, but very recently, also in Germany, we were kind of the late adopters, so to speak, in Germany. I think there were other countries that were much faster. Scandinavian countries, for instance, the Netherlands, but also Sweden. They allow internet interventions as a form of psychotherapy, and it's going to be covered by statutory health insurance as well. And this is the case in Germany only since a couple of years. When this directory was introduced, it's called the DiGA directory, like Digital Health App Directory, where you can look up apps or internet programs that will be covered by your health insurance if you want to use them. So can you ask your doctor to get a prescription for these internet programs? And there's only a few programs listed yet, but the directory grows and grows. And I think that's an important step for internet interventions to come really to the health services system. So that's one of the consequences, of course, of this research that is around. We were asking ourselves, actually, that's interesting because this also includes the unguided self-help programs. So there are some programs included here that you can get by prescription, that you can download, and that you can use at home to work through a certain problem. And that's very interesting because we were really curious about what is actually the research behind this type of interventions that are now open for the full market and for the healthcare system. And that brings me to like the real world aspect of my talk, although I'm really not talking about the real world, but it's only a very small aspect of the research landscape that we were looking at by taking kind of a bird's eye perspective. So we really stepped back a little bit and wanted to look at the available research evidence on internet-based intervention in depression treatment. And that's why we set up a consortium where we looked at a lot of manpower to look at the published randomized controlled trials on depression treatment in different modalities. And of course, the most important distinction would be internet-based interventions and psychotherapy, like in face-to-face traditional delivery models. And the group was quite large, so we do have some PhD students and also graduate students in our group at the University of Zurich who were involved. Thomas Munder had a lead in the project. He's now, I think, at the University of Kassel. And we had the colleagues from the University of Bern, Tobi Krieger, Thomas Berger, and Oliver Buhr, who joined the group and worked in, and we collaborated also with the University of Kassel with Johannes Zimmermann. The full project was pre-registered, and we had basically 3 main questions that we addressed in this project by the means of systematic reviews and meta-regression analysis. The first question was on control groups. So we were really interested in, okay, what do the control groups look like in these different trials? Do psychotherapy trials that assess classical face-to-face psychotherapy use the same control groups as internet-based interventions? Or do they differ in a way? And then the same question we asked ourselves in terms of sample composition. Do these types of trials include the same samples? Because we know that psychotherapy trials often recruit clinical samples from outpatient services and so forth. But we also know that internet-based interventions often use community samples that are recruited from the internet, like via advertisement and so forth. So we were interested, does that make a difference? And then finally, we addressed the very important question of human support in internet-based interventions, because we do know that if a therapist, a client, or expert is involved, so if there's some level of guidance, then we do have higher adherence rates and lower dropout and also larger effects. So we wanted to look at this specifically in the field of depression. So let me come to the first study. This was really to look at treatment as usual and waitlist control groups in these different trials. And to give you some background, I mean, most of you know that we have different control groups in psychotherapy research, and most popular ones are really waitlist and also treatment as usual. Although there are also fully no treatment control groups or psychological placebo, but most paper we read, it's either treatment as usual or waitlist. And treatment as usually actually is the comparison with treatments that are already used in clinical practice. So that's kind of a good thing. And it does have some advantages over other control groups, because it indicates, if it's a good treatment as usual group, it indicates whether the new intervention has additional value over what is usually done as a standard care in a certain country. So is my intervention at least as good or better than standard care? Which is a good comparator, actually. And it does have external validity, because we can make an assumption about compared to the stuff that is out there already. And it does have fewer ethical issues. So the patients do not have to wait, and you can't let patients wait if they need treatment. So it seems to be a good control condition. But the problem is, does the type, quantity, and also the quality of tau interventions, as control groups, is very heterogeneous. So it does really range from minimal mental health treatment to full psychotherapy treatment provided by trained professionals. So we do have all the kinds of different aspects that can be under tau. And the problem is we often do not have information about treatment as usual. That's also a problem. So this can be a potential source of risk of bias in trials and meta-analysis, and it can lead to the problem that we overestimate innovative potentials of new interventions, such as internet interventions. And that's a problem, and that's why we looked at it, and we try to operationalize and quantify tau intensity from these RCTs. And then we wanted to investigate the effects of tau on treatment effects in trials of psychotherapy for adult depression. And specifically, we wanted to compare face-to-face versus internet psychotherapy in terms of these control groups. We used the standard systematic review methodology. We assessed risk of bias. We registered the studies before we started to analyze everything. And we had psychotherapy modalities, at least 4 levels. So we looked at individual psychotherapy trials, group face-to-face trials, and then internet self-guided, so without any clinician, and then guided internet intervention. So these were these 4 levels, and we could also collapse them into 2 levels, like face-to-face psychotherapy against internet psychotherapy. I'm skipping the inclusion criteria. These are the classical ones. And then we try to assess treatment intensity in the tau control groups. And so we developed a summary score that is made of 6 indicators of the intensity that is delivered or provided under treatment as usual. So the first would be, and if you fulfill one of these criteria, you would get a point. So you can gather up to 6 points in a certain study. So if all patients receive care for depression in the treatment as usual arm, this would get a 1 point. Another point you could get if there were no restrictions on usual care. So patients could do whatever they wanted to do. They were not restricted to not do anything or only read a book or so. Then you could get a point if they received specialized care, such as psychotherapy or pharmacotherapy. And then treated patients received care from a mental health professional instead of a kind of a non-professional. That would be also a point. And these professionals would have undergone supervision or training, and the treatment had at least a minimum dose of 4 sessions, or at least 2 sessions with additional GP or psychiatrist. So you would get a point of 6 if you fulfill all the 6 criteria. And so this is some basic information about the data set we had. These were almost 90 trials, 15,000 patients. So these were really all depression trials from the internet-based interventions and face-to-face treatments that were available at that time. And you can see 50-50 percentage distribution of these trials. That's also amazing that the internet-based interventions have as much trials as the face-to-face psychotherapy, even more for depression, actually. And that was really astonishing to us. And again, as often, there's a lot of risk of bias involved, but I'm not going into the details today about this issue. So that's how the data look like. This is the average intensity score in face-to-face and internet-based therapies, like the 4-level discrimination of the 4 groups. And you can see like the highest control group intensity is found in face-to-face individual RCTs. And we have a point of 1.1, which is a very low score. So overall, the intensity of treatment as usual in these control groups is quite low. It was quite surprising to see that almost no study had really a point of 6 or 5 or 4. It was really 1 or 2 or something like that. And so that's the highest score. And then almost half the numbers is for group face-to-face psychotherapy and for guided internet interventions. And the much lower score is really on internet self-guided interventions that have almost a score of 0 of treatment as usual intensity in treatment as usual control groups, which is kind of an interesting finding. And if we collapse the two modalities, like the face-to-face against the internet psychotherapy trials, we will get a significant difference with a moderate effect size, actually, in terms of how intense the control group was. And if you look at the relationship with outcome, of course, you would expect the more intense the control group is, the smaller the outcomes. And actually, that's true. As you can see at the very right side, the higher intensity tau control groups had the smallest effect size overall over all 90 trials. So we have an effect size of 0.3 in the high intensity tau control groups, whereas we have the double effect size if we look at waitlist. And then also the low intensity tau control groups produce the same effects as the waitlist control trials. So that's also a very interesting take-home message that if it's labeled treatment as usual, it can produce the same effects as completely no treatment, because some really do not receive any treatment in these tau control groups. And then we have a look at like face-to-face psychotherapy and internet-based psychotherapy. We can see really like the low intensity tau produces much larger effects as in psychotherapy, traditional, as well as in internet-based interventions, of course. Yes, so I'm just going to skip that and probably have another quick look at the second study where we looked at the prognostic risk factors in randomized control trials. So having a look at the samples, how do the samples look like in internet-based interventions compared to traditional face-to-face psychotherapy? And that's really important because the way the sample looks like makes it more or less generalizable to the clinical population that you're looking at. And we know that RCTs tend to have very homogeneous samples, like they want to include increased internal validity. And that's why they really involve very strict inclusion and exclusion criteria. But that's not actually the case how patients are in clinical practice. Often they are very complex and have socio-demographic or clinical aspects and conditions that make it quite prognostically hard, and also sometimes really have a risk for treatment failure, increase of treatment failure, and also the risk for relapse and so forth. And if we exclude those patients, that's not really the picture that we have of the real practice. So there's a risk that we have low external validity if we exclude all these patients. And also, again, we would overestimate the treatment outcomes if we exclude all these patients with complex conditions. And that's why we wanted to have a look at the distribution of these patients in the different treatment modalities. So we wanted to assess the prognostic risk factors in these trials, and we wanted to compare them in RCTs on face-to-face psychotherapy and internet-based psychotherapy. So this is the risk index that we developed. It is made of 12 individual risk factors that are well known from the literature. Some are more important, some are less important, and sometimes it depends on the type of study and also type of setting, how these factors really are weighted. But these are the 12 that we really found in the literature, like older age, if you're single, if you belong to an ethnic minority, if you have no income or low income, low education, this increases the risk of a bad treatment outcome, independent of what treatment you seek for depression. Then there's also some clinical risk factors that you all might know, like high symptom severity, having a full diagnosis versus only elevated symptoms on a screening questionnaire. Then if you have a chronic disorder, if you have comorbidity, this all increases the risk. And we coded this as fully around, fully present, partial present, or absent for each of the 12. We have a score that ranges from 0 to 12. And let's skip that. Again, approximately 100 studies. And that's how it looks like. The first important thing is it's the gray bars. I hope you can see them. They are on the right-hand side, these gray bars. This is the amount of data that is not reported. So most of these variables are not mentioned at all in the trials. And for instance, in internet-based interventions, looking at age, people with older age, it's not mentioned in half of the trials if patients are included of a certain age. That was really astonishing. And in terms of ethnic minority, both types of research, face-to-face psychotherapy and internet-based interventions, do not a good job in reporting whether ethnic minority patients and clients were involved. But if they do, they seem almost similar distributions, like in terms of inclusion of people from ethnic minorities, internet interventions, and trials from face-to-face psychotherapy seem to be quite similar. This is not always the case. Like there's other variables, like in terms of age, but also no college, very low education is much less in internet trials, but also people with no occupation are much less enrolled in internet trials. Low income is a little bit less. And if you look at the clinical aspects, full diagnosis is available in only very few trials on internet interventions. I mean, you can argue and discuss about the helpfulness and meaningfulness of diagnosis, but most of the trials do not have a formal diagnosis. That means that we do not know if the patient has only depressive symptoms, but anything other than that. And that's very important in terms of clinical generalizability. Symptom severity is higher in traditional face-to-face psychotherapy. Patients with chronic causes much more often in these samples. Comorbidity, you can see much more often. Comorbidity on a personality disorder is almost no reporting on this issue in internet-based intervention trials for depression, at least in the database that we collected to a certain time point. And also, so you can see some striking differences here. And we put everything together and compare our index, then we can see clearly that individual face-to-face psychotherapy trials include the patients with the highest prognostic risk factor. So they have the kind of the more complex cases. Although the index, you can see at least in the median is in 0.4 something of this index, it's not much high, not very high. So we never really took the full range of the index and found it. So again, patients with really complex conditions are also rarely included in face-to-face psychotherapy trials. But then we can see the lowest score is for self-guided internet interventions, or the completely standalone interventions. They recruit patients that have really, at least from our analysis, low risk of a prognostic bad outcome. So they seem to be the more homogeneous and a little bit better off clients that are enrolled in these programs. And if we collapse like the internet against the face-to-face, we find an average effect size of 0.75, which is quite substantial. So we can clearly see that face-to-face psychotherapy, group or individual, include kind of different patients compared to internet-based interventions. So it's really hard to compare these samples. So yeah, this is the conclusions from that study. It seems that traditional psychotherapy trials kind of target the target clinical population by including patients with complex conditions more than ICBT, internet-based intervention trials. One explanation is that internet-based intervention trials tend to recruit community samples. So as I mentioned before, they advertise the project in certain media, in internet forums, do some advertising and assess these patients from the community, but not from clinical settings. So that might explain some of these differences that we found. And our conclusion was, at least, that the comparisons of the results from internet and face-to-face psychotherapy trials, comparisons are really problematic because in terms of these reporting of prognostic risk factors, the samples of those trials may not be drawn from the same clinical population. So can we really compare these two worlds? Also, we found that the reporting of prognostic factors in these trials was really not optimal, specifically in IBT trials. And so we cannot really talk about how can these results be translated to clinical practice, to clinical routines. And I mean, that's a problem because that's what we want to do. We want to make an assumption about how can we use this intervention in clinical routine, not only in trials and the lab under highly controlled conditions with kind of a probably specifically selection of clients. If we want to transfer or generalize our findings to the real world in a way, and it seems that based at least on these prognostically relevant factors, it's not as easy. So I think I'm going to stop here. I think the time's almost up. Is that okay, Miguel, or should I continue for a second?
You are skipping the third part, if I understood correctly, right?
Yeah, probably, but I could also show one slide for that.
It's up to you. I don't know if people have, or perhaps we can stop here and see if there are questions.
Sure.
If there are no questions, perhaps you can continue 10 minutes more or something like that.
Cool.
Okay, is that a good idea?
That's a very good idea. Thanks, Miguel. So are there any questions or comments? Okay.
People want you to go on.
Yeah, that's cool. So if you have a question, just unmute. And I mean, we were not a big group, so you could just unmute and make yourself visible. Okay, so the role of human contact is also something that is very important for interventions, because if we want to have the benefits of scalability, we should also deliver interventions that are fully automated. And as I mentioned before, these fully automated interventions are already available, and they are also distributed in Germany across these DIGA directory. And so we were really wondering, what is the difference of guided versus self-guided interventions? And is there a big difference? And I skipped the intro because it has been found that some guidance helps to increase adherence and also produces lower dropouts. And there's also some indication that having a guidance by a therapist in the program, for instance, once a week, feedback via email or so, increases the effect sizes. So we were really curious about what is about this degree of contact and how is it associated with outcome. And we wanted to actually replicate a important study that is quite a while ago, that has been conducted in 2012 by Johansson and Gerhard Andersson, which showed that the more guidance you deliver, the higher the effect sizes are. And what was something that we were very interested in was also often in these studies, you just have a clinical interview. But there is some very specific restricted level of guidance by delivering a clinical interview at the beginning of the intervention. And back then, Johansson and Andersson didn't find a significant difference between if there's an interview or there's guidance in the program. But that's probably a problem of statistical power, and so we wanted to replicate that. Again, we had like our 50-something studies from the internet interventions, and we had approximately half the group was guided, the other half was unguided. And we coded level of contact. There were 4 levels, so no contact at all, fully self-guided. And then there was a score of 1 if there was some contact before the intervention, like I mentioned, a clinical interview or something. Then there was a level of 2 if there's contact during the intervention. And then the highest level of contact was the 3 if you have contact both before and during the intervention. And these are the results. So we again found a similar pattern as Johansson and Andersson found. But we did find a significant difference between before treatment against like the clinical interview against the no contact at all. So we did find that making an interview before the intervention starts does help to increase the effects, and also slightly, of course. It was significant, but there's a slight increase in the effect size. And it also reduced dropout and increased adherence. And so these are the effect sizes. You can see if you deliver both during and before the intervention, you get the highest effect size in terms of depressive symptom reduction of 0.57. But it's less than half of it if you deliver your intervention fully self-guided without any contact. And I'm gonna skip that. We did some various sensitivity analysis, but in the end, we were really wondering whether you could deliver these fully self-guided interventions in terms of their clinical relevance, because an effect size of 0.22 is really small and by some authors really considered not a clinical relevant effect size. And so this gave us a little bit food for thought also when we think about the directory that I mentioned in the German healthcare system, where unguided interventions might be available for clients and patients. So this is my overall take-home message for today. I think we have many trials, and we probably do not need more of the same, meaning like waitlist controls, studies from the lab, or with highly selected self-selected community samples. We need new samples that are clinically relevant, and we do have to use really meaningful control groups to figure out, okay, what is really the effects of this new intervention. We need that people report what happens under tau control conditions. So that's a black box and we do not know what happens there. So I think it should be really standard to report what has been delivered and utilized under tau. And we need more diverse and clinically representative samples in internet-based intervention. I think we did not make a very good job. I mean, there's good studies out there who have tried it and it's really hard to do so, but we have the benefits and the opportunities to reach underserved populations, but we haven't done very much in this direction. We need larger studies that focusing on effectiveness more than efficacy, like multi-site under clinical routine practice conditions. We need to know what works under which conditions for whom. Like one word would be individual treatment selection. We need to know in which cases it might not work or produce too small effect sizes. And I think we are at the beginning of this stage. And overall, the papers need to be on a high standard to really be able to interpret the findings. Otherwise, we could not make an assumption about their clinical relevance. And in the end, as I mentioned before, it should be questions if fully self-guided interventions should be delivered as a treatment in people with a kind of mental health problematic, or whether they should only be applied in prevention, because they have really the clinical potential is not as big as the guided interventions, and we should really think about how we should use them or not. Yeah, thank you very much for your attention, and maybe you have one or two questions.
Thank you so much, Marcus. Wonderful intervention and presentation. So we are open to questions. I'll start if nobody asks questions.
Sure.
What is the role, on your perspective, on AI on these interventions? How do you see artificial intelligence in the middle of this?
I mean, there's many different options you have. If you think at, I mean, artificial intelligence, I would rather talk about using data to learn in the system and to enhance the system. And psychotherapy research has a long tradition of doing so. So I think with routine outcome monitoring, we exactly started with this principle, taking data from real clients, learn from it, and provide recommendations and feedback for the new patient, for a certain therapist, or how to tailor the treatment. And we have huge potential in these interventions, of course, internet delivered, to use algorithms to make the system learn and get better. One thing that I see kind of a little bit more critical, and I'm not sure if there's a question out there. No. What is a little bit more critical is like another hype coming up on like chatbots and whether human large language models could provide psychotherapy, because I already saw some headlines and newspapers that really made up with this provocative statement that in future a chatbot would provide psychotherapy. And I think that's really not a good development, because of course these models getting better and better, but they have to be trained on psychotherapy as real psychotherapists. They undergo 4 years of training. They have a test, an exam that they have to pass, and they are supervised all the time. But no one thinks that this is necessary for chatbots. So chatbots have to be trained very specifically on certain problems. They have to be checked. They have to be supervised. And this is all left out. And I think the hype is a problem because we will get studies, probably not very high quality, and they will gain much attention, and we will start delivering chatbots without knowing what they are doing. So I have a little bit of critical perspective on that, but there's huge potential, of course.
Okay. Thank you very much.
That's an excellent point. I mean, because that's the future. It's already started. And I think chatbots, if they have a very specific target that are dealing with, like more like a digital agent, for instance, answering questions on the healthcare service systems, like easy things that are easily learned and there are not many errors to make. I mean, they can be very helpful in psychotherapy because they could address topics and questions that clients have. And if they cannot see a therapist, they could ask a chatbot about what types of therapy do we have and how can I access it? I mean, there's probably easier questions that could be very helpful to deliver via a digital agent or communication agent. That would be very good. And I think that will be the future, like a call center.
Thank you. Other questions? Marcus, you were very clear, and I don't think we have more questions. Actually, I was wondering regarding your answer on AI, imagining a system that is perfect, that is a perfect therapist. Do you still think that it will work without human touch? Or that people still need
for some,
and that is a true ingredient of psychotherapy somehow? What is your guess on this?
I mean, we have all our different opinions on that. I think it will work for some who have, like, it would be enough for some, but it won't be enough for most, because there's some things that are left out probably in pure internet-based interventions, be it via a chatbot or an internet program. I mean, some processes that are deemed relevant for psychotherapy outcomes are left out. Like, we can see each other here, but we have a two-dimensional space now, and we cannot really, we're not in the same rules, or the full embodiment and everything is really not inherent in that type of interventions. We do not really know how important it is, but we do have an idea that it is probably important. And if there are clients who do not probably need it or do not want it, it might be helpful as an alternative to have different options for psychotherapy to at least deliver some treatment. So there will be definitely a part of the services systems where these types of interventions will be used and will be useful.
Okay, makes sense. Makes a lot of sense.
What would you think, Miguel?
No,
you're much more experienced.
I agree. I agree that probably it depends on the clients and even on the problems, right?
Absolutely.
That for some people it will be enough, and that other people need contact with a human person to interact with someone to, you know.
Yes.
So I really agree with you with your. Okay.
If we think about measurement-based care, we can decide which would be the best decision for this client now, and whether we would switch to human contact, or whether the person is well on track with a certain intervention. So I think we do now have the tools and opportunities and options to have more intelligent treatment trajectories. But I don't think that one size fits all.
Sure.
No.
Sure, makes sense. So if there are no other questions, people are thanking you about the presentation. So
thanks for your attention. Thanks for your
thank
patience.
you so much for this wonderful presentation. Hope to see you soon somewhere. Okay.
See you soon.
Ottawa. Bye-bye.
Bye-bye. Take care. Bye.
Thank you.